السلام عليكم، مساء الخير، يعطيكم العافية. معاكم دكتور أمجد عبيد. أنا استشاري طوارئ، طوارئ وديزاستر. أنا حاليا أشتغل كونسلتنت في مستشفى دكتور سليمان حبيب وفرع الخبر. يشرفني أكون معاكم، وإن شاء الله تكون محاضرة جميلة وتستفيدوا منها إن شاء الله بإذن الله. طبعا حنتكلم. I will speak in English, and if you might have any point or any question, please feel free to stop me, or just raise your hand, or just use with your voice, and we will stop there. Okay. So I'm gonna talk about pitfalls and pearls in emergency trauma care. So as you are aware, emergency medicine is involved in every aspect of emergency care. So it's trauma, cardiovascular, uh, stroke, metabolic, all types of emergencies. We deal with them as an emergency medicine specialty. Trauma, we are really one of the really major role player as well, and lots of pitfalls. I will things that if we did not pay attention to it, it might have a very bad and dramatic bad effects or bad impact on the patient. So let's go ahead and we'll just start. Okay. So the first one is that we'll just talk about I've got okay, nothing to disclose. Okay. Nothing to talk about. I'll talk about clinical situation. So I like it to make it more applied, and I want you to live with me the situation and the scenario. So you are in emergency department and team leader on the shift. You arrive to the trauma bay. A few minutes after a trauma activation, there was an 18-year-old male was hit by a car. 6 members of the emergency team are in the bay. You ask for a hand over and an update of the situation. You need to have a handover. What happened? You just came to the shift. I'm just starting my shift. What's going on? I've got an 18 years old male who was hit by a car. The patient that told the team that told you, oh, well, this was a patient brought by EMS, by the Red Crescent, for example, as we have it in our Saudi Arabia. He was ejected few meters when he was hit by a car. Vital signs initially showed that he was having sinus tachycardia. Blood pressure was on the borderline A. So A is intact, and now we are moving to evaluating B. A is airway. We are moving towards evaluating B. So that is simple case scenario. So now we talk about how do we approach patients. So when you deal with a patient with a trauma or acute emergencies, we don't deal with them like any other patient, right? Like you are sitting in any other specialty or sitting in a clinic. We go with history, present illness, past illness, and we go with the physical examination, the laboratory, and all of that. So there's something called vertical approach and something called horizontal approach. Don't forget, in acute emergencies, what is in trauma, we talk about trauma here. We have got no time. We need to do lots of things at the same time because we have got no time. So time is we talk about time is very crucial, and we are working against the time. We are working every minute makes a big difference. Every minute we want to save his life. We don't want his brain to have any brain damage. We don't want to have any brain anoxia. We don't want to be hypovolemic. We don't want to be hypoxic. If the patient was hypovolemic or hypoxic, especially hypoxemia for a long time, he would have irreversible damage. The aim of a proper or appropriate emergency medical care is that to have this patient back to his normal mental status. I don't want to get a young man who's 18 years old, has got a polytrauma. Yeah, I saved his life. Yeah, you saved his life, but he's got already a brain anoxia, and he'll be living for the rest of his life on as a vegetable, just sitting on a bed, feeding him through a tube, and even putting a tube for it to ventilate or to breathe. So there's something called vertical approach, and there's something called horizontal approach. Horizontal approach is what we deal actually in immediate life-threatening conditions. So vertical history, examination, management, but in method of horizontal approach, we deal with this. So what do you think? We should go with horizontal approach or vertical approach? Of course, you will all agree with me that we do things at the same time. While I'm taking history, my colleague is taking care of the airway, my other colleague is taking care of the circulation at the same time. We don't have time to go from one thing to another. I will not wait for the physical for intervention till I finish all my complete history and physical exam. No, I do things at the same time. So we call it vertical approach and horizontal approach. Now, when we talk about follow some guidelines, first of all, there should be a trauma team leader. Anything which has got no identified team leader will be a chaos. Like احنا نقول مثلا عندنا سفينة, there should be a captain for your boat or ship. If there is no captain, there's no proper leader, ship will not move. It will sink. It will just go around itself. So a proper team, a proper trauma code, it has to have a trauma team leader. So trauma team should be identified. We should have a primary survey. So when the patient comes here, we said always have a primary. What is primary survey? Is a quick completed examination for a patient within 30 to 60 seconds. We talk about seconds here. We don't talk about minutes. We don't talk about okay, taking half an hour or 1 hour. We talk about 30 seconds only. Number three of the follow guidelines, trauma management. What kind of trauma management? Do I need to do any heroic things in the emergency? Do I need to be the hero? We do only just few basic things that we can preserve life and we can preserve her circulation. So this has got a systematic approach. It's not haphazard. It's not like when Amjad treat the patient different than Muhammad, when Muhammad treats the trauma patient different than Rashid, or Rashid is different than Abdullah. We all have the same approach, systematic approach, and we have to access the way we access, well, the way we assess and treat those injuries. And then trauma care equipment. What equipment do they need? What are the essential equipment? Includes backboards, cervical colors, airway management tools. Very simple tools. Those tools are there for trauma management. Am I using them properly? They are good tools, but of course, if tools are not used properly, will have a disastrous effect on the patient and of course on the outcome. Let's go with the journey today with our pearls. When we talk about pearls, إن هي عبارة عن أشياء اللي تكون يعني اللي يقولون the same thing which is something takes you about the tricks and coming from experience and coming from knowledge, coming from studies, and we put them all into pearls on something that you don't want to miss in trauma management. Let's go now with it. So primary survey, how long does it take? We just said 30 seconds, should be not more than 30 seconds. So airway, breathing, circulation, and disability. I don't go to B before I finish A. I don't finish A. I finish C. Then I go to D. I have to have a quick approach. Now we'll say, is it ABC, CBA? What is it? So, but I mean, I should do it within 30 seconds. So say, oh, I've done my primary survey. Well, my primary, and of course, because it's too short, ultra short, we can do it again and again and again, and we can keep on repeating it because the patient's trauma, they're not stable. It's not like he comes here with only a simple complaint. He might deteriorate. Maybe he's holding himself now. Maybe he's stable now, but later on becomes sick or becomes deteriorating. The bleeding is getting worse. So 30 seconds, you have to remember those times. 30 seconds for your primary survey. Now, if you know about, because I mean, actually, I'm fan of Formula One, and I do work with Formula One medical team. I'm the chief medical officer of Bahrain, and I work with FIA as well for the Formula One all around the world, and we can see how much we have a teamwork. You can see all those team here. What they do is that they are here to change the tire for a patient. You can see. So that took how many seconds? Took about 2 seconds, 3 seconds. Okay, that video takes only 3 seconds. See the team, how did they work? They work in everyone knows his job, and talks about they changed four tires in less than 2 seconds. Imagine how long does it take you to change your tire? For me, it will take about 1 hour to change the tire because I need to put this. I'm very tired, but those are team. There are about 20 people or 20 people here around and in this small area. And if anybody does a mistake, the team will lose. They will lose. They talk about milliseconds when they do racing in Formula One. Milliseconds we lose it. Here, everyone knows his rule. They're trained to do that. They know their tools very well. They know how to use them very well. So, emergency trauma scene. It has to be dynamic. It has to be a very challenging environment. It requires a systematic approach. The scene must be assessed for safety if there's any trauma scene, whether it's in the hospital or out of the hospital. And of course, the patient condition must be rapidly assessed and evaluated and re-evaluated. And we have to keep on re-evaluating the patient till we reach the hospital or till we reach his intensive care and is fully monitored. When you talk about fully monitored, I mean they are always continuously asking and checking his vital signs. If there's any changes in vital signs, and again with the condition, maybe we need to have another intervention, either radiological intervention or even surgical intervention. Let's go next. So point number one, trauma management. We just said about the approach. Is it horizontal or it's a divert? So we all agree that it's going to be horizontal approach. Predetermined rules, yes. I know. Amjad is excellent in doing airway, so I'll take the care of the airway. Well, Muhammad is very good at doing central lines. Okay, Muhammad, you do the central lines. Well, Khalil is good. He'll be doing the evaluation and examining the patient. I've got my tooth or my nurses. My nurse is gonna be Shirley is gonna be the documentation. Ansi will be doing the IV access. Carol will be doing my medication. So everyone knows. So we've got a trauma. I don't need to be chaos. I don't want to have three people doing the same thing. Only one person doing it, and he knows what he's doing. So it's called predetermined rules and regulations. So now when we go talk about pearl number two. So pearl number one, an approach. Okay. Pearl number two, golden hour. What do you mean by golden hour? What do you mean by golden hour? Golden hour is the time which is the clock starts zero once there's a trauma. So that's zero. So goes 1 hour. Within 1 hour with 60 minutes. Okay. I'm not saying like 60 minutes per se, 60 or 55 minutes. It's the time that we can do save lives. If the patient remained hypoxic, if the patient remained hypovolemic, hypoperfused, we'll have our brain are the most selfish organ in our body. If we don't provide him oxygen, it will be have a permanent damage. You don't, the last thing you want. A young man, 18 years old, 20 years old, 22 years old, has got a motor vehicle accident and he is living in front of his family with a brain anoxia. On a bed, he's a bedridden, anoxic, okay, on nasogastric tube, on or PIC tube, on Foley's catheter, coming to you with bed sore and sepsis. That's horrible. If we can do something for trauma management, we can do it in that 1 hour. We have to prevent hypovolemia, prevent hypoxia, prevent all the complications of trauma by early intervention, early diagnostic, early decompression, and lots of things can be done within this 1 hour. So we just said the golden hour rule. Time is crucial. First hour is crucial for survival. Swift action. I know what to do. I don't want to have somebody with a motor with a major injuries and I take him to a small مستوصف يعني مركز صغير ما عنده any capability of treating with trauma. And you take him to a proper place, a proper trauma management. So making a difference is that how can we make a difference in trauma life support? We have got patients coming with trauma. We have got lots of big highways. We've got lots of sporting events. If we don't really manage ourselves, we'll end up having our young people will be victims, not victims because of trauma only, victims of our poor management, our poor trauma system, which is something which we don't want as doctors and for you, our future doctors, and our later on our generations. So let's go to clinical situation two. Another case. The EM team lead, the emergency medicine team lead, activates trauma code for a 24 years old man who fell off a horse and was kicked in the face. His initial GCS, eye movement is 2, motor is 3, and verbal 4. So his GCS is about 9. Okay. Now, we've got a trauma code. A young man, 24 years old, fell off a horse, was kicked in the face. So fell off the horse يعني واحد طايح من حصان طاح على الأرض. What do we suspect? We suspect maybe head injury, maybe cervical injury, maybe suspect also a cervical spine, a thoracic spine, or even all spinal injuries. And he was kicked, maybe a blunt injury to the chest or abdomen, and the GCS is low. So all of this only from this 2 sentences of the history. Now, trauma team arrived, EM team leader handed over the patient and attempted to leave. The trauma surgeon said, no, 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 no. You as an EMS or a paramedic, do not leave. I want you there. I want you to help me. I want to start for me the infusions, post-intubation. I want you to occupy or accompany the patient to CT scan. I want you to manage the CT scan sedation if I want. So Why emergency medicine consultant is needed that time? So we've got the surgeon, but emergency medicine consultant or emergency medicine trained or board certified personnel, he will be a very major key player in such a trauma care. So what we do is that we know how to do proper intubation, management of the airway. We know how to fix the circulation by doing central lines and sedations and fusions and pressors. And even if we need to give some sedation for the patient, we will be as well our expert as well to do that. So trauma team leader system, how do we do that? We need to have a trauma team leader. We have to have a team leader standing at the tip of the tip of the bed, assigned rules and everyone. So we can see here, you can see here, this is the team leader standing here. You can see him here. He should not be somewhere else. You should be clearly identified that he's a team leader. And here, the nurse or the paramedic who is doing the documentation. She will be always documenting exactly what are the orders given by the team leader. And of course, all those nurses are doing their procedures and their maneuver as well. So clear rules and responsibility. Point number 3, team leader. We have to have, everyone has to have his own proper communication skills, coordinations, and of course, the team leader should be capable and knowledgeable to take a decision. Well, this patient needs to go to CT scan. I will not be, the team should not be hesitant. Well, this patient needs to have a proper, to apply tourniquet. We need to start him blood. We need to give him some antibiotics. This patient will go to OR immediately, will not delay him. This patient, we need to activate the intervention radiology. So the team leader have to have the decision and to be decisive as well. So another situation, 2-year-old boy, victim of motor vehicle accident, admitted to ICU as severe head trauma. Now, what do you think? The picture was posted in admission. So a child, motor vehicle accident, ICU admitted after head injury as well. And then after 3 days of admission and we saw this picture on social media. Imagine it. What's going on with social media? What do you think is wrong with this? What do you think is wrong with this picture? Is it something big or nothing is there? What do you think? Anybody can put me in the chat. Can you think can you let me know anything wrong with this picture? Can you tell me what's going on with this picture? Well, exactly. Thank you very much, Asma. It's the C color. We should not keep patients. We should not be keeping patient on C color for 3 days. Imagine it. C color should be cleared as soon as possible. Excellent, yeah, Asma. The patient is not conscious. He's intubated. We know we need to immobilize the neck. That's fine, but to keep him on a C color for 3 days in ICU, and this was only posted on social media. I mean, the team did not pay attention to it, so that's really bad. That's really bad. This patient was missed, and or even we did not we were actually, it was a torture. Imagine you put a C color in your neck. It's very painful. Okay, not only suffocating you, it have got a pressure. It can even some lots of side effects on that. I'm not going to go through it, but we have to clear the C-spine as soon as possible. Okay, so there are different types of C-spine. Okay, a soft color, hard color. If you need to put a mobilization, you need to put the proper one, but not the soft one, of course. Backboards, spinal boards are only used to transfer patient. We are not using them to keep the patient on them. Once we had one of our conferences, we had a competition that we kept. I will come to wire removal. Yeah, wire removal, we remove it because it is, imagine if you put a C color, you're overextending the neck. Somebody who is intubated. We did for him intubation, and neck is immobilized. You just immobilize, but you need to put a C color. It has got lots of pressure necrosis. Okay, it will have kind of a pressure here. It even can compromise the airway as well and hyperextend the neck. So it has got lots of contraindication to keep it for 3 days. C-spine should be cleaned as soon as possible. As far as his radiology and is it clean, we can remove it. So of course, so a patient may have a cervical spine. Yes, it has to have a different types of cervical spine mobilizations, not only a C color, putting it only to preserve it. There are other difference. Not only cervical should be a Philadelphia one. If there's a spinal surgery to be done, that's a different one, but not the same one which was shown in our picture as you just said, Mr. As the question here. Backboards, we don't keep backboards for a long time. We use it only to transfer a patient. As I told you, we had once a competition, and we said whoever is going to be on the backboard is going to win an iPad. The maximum one who was able to stay on the backboard without having severe back pain was about 1 hour and a half. So imagine you keep a patient for 3, 4 hours, 6 hours on your backboard in the emergency. It will be severe painful. Maybe many patients they had some sores, some bit sores because of the cervical, because of the backboards. So we remove the backboards, we remove the cervical spine as soon as possible, and they're only used for transportations. Once we have the patient is clear, remove it, and you can mobilize it. You can put 2 pillows, you can put a tape, but not always keep them hyperextended on that hard cervical, because that would be it's actually torture for the patient. Okay, so now we said the tools, whatever equipments we have in the ER, we have to clear them. So clinical situation number 4 will come to another scenario. 25 years old, intoxicated man who was brought in under trauma activation after falling from the second floor balcony. Intoxicated, maybe he was taking some drugs, maybe he was taking alcohol, and he was brought in. He fell down from a second floor balcony. The patient is agitated, not cooperative with the exam. Okay, but he was given benzodiazepine. Patient was calmed down, and then we were able to proceed. Now, patient is intoxicated. Shall we treat him like anyone else, or a special patient? Let's talk about it now. Intoxicated patient, agitated patient is not only he's hypoxic. Okay, so intoxicated patient is we need to make sure that agitation is not due to hypoxemia. In a matter of, in the case of a trauma, okay, it's any intoxication, any agitation is a sign of hypoxemia, okay, or head injury or other critical conditions. We'll not say, oh, he is psychiatric, he's becoming psychosis. No, we have to rule out that this patient is not having such a critical situations. So ETI is a endothelial too. So I mean, if this patient does he really need to be evaluated? Does he need to be intubated or not? So agitated patient, whether he's intoxicated or not, we have to rule out intoxication, we have to rule hypoxia, or there's a bleed, or there's something wrong with his brain. So we have a lower threshold to intubate such a patient just to secure his airway. The last thing I want to do is that to lose somebody because I did not intubate him, I did not secure his airway. I have to make sure that I do care about his airways, breathing, and prevent any hypoxemia, or prevent any kind of a problem with breathing, aspiration pneumonia, which could happen very easily in our situation. Okay, so agitation in a trauma equals to endotracheal intubation. I need to make sure that I have to secure the airway. We can do the endotracheal intubation either by endotracheal tube or LMA, different method, whatever your team is more comfortable and confident to do that. Okay, let's go to our situation here. Another scenario. Are we all okay, guys? Or are we going too fast or going too slow? Just put for me in the chat. I'm putting the chat here next to me so that I can read it. Are we okay? Are we going too fast? Or I'm going to okay, thank you. Nice, thank you very much. I'm happy that you like it. We go to situation number 5. 7-year-old boy, he was climbing on a bookshelf. He lost balance and fell off the back, putting the shelf on the top of him. So what shall we do? 7 years old boy climbing a bookshelf. عارف هال شوية, they are a bit naughty boys. They like to climb, and the whole bookshelf fall on the top of him. What do you think we have with our patient? So present with significant, he's got facial trauma. He's got decreased level of consciousness. So the doctor there, an excellent and a very enthusiastic emergency physician, said, oh, let me protect the airway. I will intubate him, connected to ventilator. Perfect. Excellent. Fine. Spinal precautions. Excellent. I agree with you. Thank you, Right. ABCs. Wonderful. And be careful not to move him right away. That's fine. Of course, you need to take him in a proper way by the EMS system, by our paramedics. So the patient was intubated and connected to ventilator. Few minutes later on, the patient arrested. Wow. So why? We were excellent. We did, he fall down, he came to us, he's got significant facial trauma, decreased of consciousness, came to us, we intubated him, we did not delay, we put him on ventilator. After a few minutes, he arrested. So what do you think? What do you think was the problem, guys? Let me know. What do you think? Tell me. Okay, no cheating. Circulation, ICP, chest injury. Exactly. Thank you very much. Dope. Wonderful, Yasma. It's a dope. Yes. What is dope? Dope. We talk about a pneumothorax. So this child had a trauma to the chest. Okay, had a small had a small pneumothorax. But when we intubated him and we connect him to the ventilator, we converted the pneumothorax to a tension pneumothorax because we're putting pressure, right? So what we do is that we resuscitate, then we intubate. Okay, we intubated him because, oh yeah, he's got the, I'm gonna intubate him. But we have to listen to the chest properly. We have to evaluate his chest. We have to evaluate his breathing, isn't it? We have to make sure that we've got an ultrasound. Fast, we're gonna come to the EFAS. Make sure there's no pneumothorax, because with this intubation, early rushing to intubation, without making sure there is no pneumothorax, we converted pneumothorax to a tension pneumothorax. And that's exactly the dupe pneumonic. He arrested. Well, the doctor there was excellent. He knows that the dupe, and he did what? He did the decompression. So always resuscitate before you intubate. So it's not only ABCs, it's a CBA. What means CBA? Because if somebody's hypotensive, you also take another scenario. Somebody coming to you after trauma. He's got trauma and he's hypotensive. Well, I'm gonna intubate him. That's fine, but this guy is bleeding somewhere. This guy is losing lots of fluids, lots of bleeding. I'm going to transfuse him blood, optimize his develop as circulation, then check his breathing is okay. Then I want to intubate him. As far as I'm able to ventilate him, I'm okay, because any intubation, you'll be in the rapid sequence intubation, you'll be giving some medications. Those medications will knock him down, will even make him hypotensive. So we have to make sure that we don't want to do that. And exactly, Jamal, X, A, B, C, D, E, X, and this is all the guidelines of 11th edition of the ATLS, was just published last month. So it's called X, A, B, C, D, E. Excellent, yeah, Jamal. This is the latest recommendation of ATLS. So we have to optimize my circulation, then optimize my breathing. Then I can go with my intubation. Very good, excellent. We go with that. So the same situation. Okay, I think I'm gonna. Okay, so we have to evaluate the B, because we have to make sure that he's got no pneumothorax. All right. Breathing, auscultation. Okay. Breath sounds for abnormalities. Observation, any patient's movement for his breathing, any chest movement, any respiratory efforts, and then we can go with evaluating the breathing. Even we can do the EFAST. There is something called auscultate and palpate. Wow. So auscultate, I want to auscultate the chest. I know nowadays they said, oh, you having your stethoscope, you are an old-fashioned doctor, but I still want to auscultate. I know it's not as very sensitive as an ultrasound, of course, but it's still old as gold. We still need to use our stethoscope. We should not just throw them away. Auscultate the chest for any decreased air entry. Okay, and then palpate. Can you tell me palpate for what, guys? Can just put them in the chat. Palpate for what? Auscultate. احنا قلنا auscultate. We'll auscultate for air entry. Palpate for what? Rib tenderness. Excellent. Emphysema, crepitus. Wonderful. That's very good. Crepitus. Wonderful. I love this. Crepitus. Emphysema. Surgical emphysema. We've got a chest injury or thoracic injury that I have to pay attention to. So just put your hand, and actually physical examination is a kind of we give you a free information, a free info, a free diagnostic tools for you, that you can do it with your patient with no time. We don't need any tools. So any kind of fracture ribs, crepitus, emphysema, that would be really good. And of course, we need to go if there's any tenderness, you need to go for indication for imaging. Well, that's absolutely right. Wonderful. Excellent. You're doing very well, guys. So evaluate B by auscultation. And the word here is, I like it, and give a hug. Okay, what do you mean a hug? hug. Just embrace the chest. Hold the hug as we have it in our as I saw in the diagram before. Surgical emphysema or subcutaneous emphysema or grimsing, which is something bit more painful as well. Different. Excellent. Excellent. So we go. Another situation. 31-year-old man with a crush injury to the chest. He was suspected of having a tension pneumothorax by the EMS. Oh, wow. Those EMS are good. Those paramedics are excellent. He said, crush injury, have got a tension pneumothorax. What I'm going to do, I'm going to decompression, do it for him. I give him a needle decompression at the second intercostal space. Gush of air came out and the vital signs are stable. Oh, is it good enough or not? Okay. So the patient, after 30 minutes, the blood pressure dropped again, but the fast was negative. Okay, thank you. Yeah, Al-Zain Mahdi. Al-Zain Mahdi. Okay. Al-Zain Mahdi, absolutely right. So needle decompression is not at the second it's at the fifth So he did a kind of an incomplete decompression. So 30 minutes or later on, patient became hypotensive. Fast was negative, and then patient was pushed to CT scan, and then he coded. Said why? Because we did needle decompression, what was not effect was complete. So per number 8, decompression techniques. So we have to, first of all, decompression location is at the fifth, not at the second intercostal. So this has been actually from the 10th ATLS guidelines. Avoid incorrect location, which is not the second as the fifth intercostal, and avoid partial decompression. Complete decompression is crucial. Avoid partial because partial it will reaccumulate again and the patient will be arrested. And you will send them to CT scan and will just simply the last thing you want that you send a patient with a trauma or a stable patient to the CT scan and he arrests there. The last thing you want to lose a patient on CT scan, and that all because of a miscalculating that. So thank you very much. I agree with you, Ya Majid. ICD, we'll come to it in a moment. Thank you very much for raising this point. So needle decompression equal to tube. Absolutely right, Ya Majid. So like Isa also said, any needle decompression equal chest tube. ما يصير تقول needle decompression ما نعطيه شيء ثاني. It's not an option. I put a needle so if there's no pneumothorax, you did create a pneumothorax by putting a needle decompression. So once you decide to put a needle decompression, you have to have an ICD. So always follow it up with a chest tube with an ICD. Okay, excellent, very good. You're doing very well, guys. MashaAllah alaikum. Now, trauma scoring system. We've got lots of trauma scoring system, lots of things, different trauma accreditation, trauma-induced coagulopathy, clinical scores, emergency room transfusion score, assessment of blood consumption score, hemorrhage, the Van score. Lots of scores. I will not going to mention them here, but you need to be familiar with whatever is used in your own hospital. But at least you know that there are something called trauma scores, trauma scoring tools that you have to pay attention to. Now, let's go to page number 10. So we said limitation of EFAST in our patient. We said, okay, I'm gonna do the primary survey, I'm gonna do the EFAST, but we've got some limitation as well to EFAST. What is the limitation of EFAST? It is the retroperitoneal. Okay, can anybody answer me on the chat? When do we get a retroperitoneal bleed? In which cases? Yeah, somebody has to have a trauma, fall down, came, I did from EFAST, was negative, I'm fine, خلاص. EFAST is negative, patient is fine. Falling back, I want to be more specific. أي trauma تعطيك retroperitoneal hematoma؟ أي واحدة؟ hemorrhagic I'm talking about traumatic. لا, I'm talking about trauma يا شباب أو يا شابات. Not about just trauma. Which fractures give you retroperitoneal يا شباب؟ seat belt. اوكي جربنا يا سلافة. roll over pelvis. Excellent يا زينب. Yes, pelvis. رماس وزينب they did it. Pelvis. Excellent. Pelvic fractures. When you get a pelvic fracture, طبعا the amount of bleeding is a lot of bleeding from the pelvic fracture. So احنا we did not immobilize the pelvic. We not put a pelvic binder. حتى لو ما شفناه حتى لو كان EFAS negative. That's why we always go for a CT scan. صح ولا لا؟ فthose are one of the limitations. So معناته ان EFAS is negative. Oh, he's hypotensive بس اي فاست is negative معناتها ما عنده bleed. لا يمكن يكون عنده bleed لأن في limitation of the e fast that we cannot see the retroperitoneal bleed and which can be really big. So, retroperitoneal bleeding is a complex area making it difficult to visualize e fast. Is not always EFAST is always a tool that we roll at any intra-abdominal bleed. طيب فعرفنا الإيفاست في limitation. طبعا the good thing about EFAST you can do it, repeat it, can be done with many people, will not harm the patient, and you can keep on doing it, monitoring the patient. It's a beautiful tool. لكن make sure that في حالة الريتروبيرتونيال والله عندنا لك عليه إنه not very accurate. Now let's go to pearl number 11. Blood, and blood is the fluid of trauma. يعني when you have a trauma, you bleed what? Patient كان with trauma, right? عنده fracture femur مثلا. He bleed what? He will bleed ماء وملح يعني normal saline. ولا he will bleed blood? He will bleed blood. Simple. As simple as that. We don't bleed ماء وملح. We don't bleed normal saline. ولا ringer lactate. We bleed blood. We lose blood. We don't lose fluid. فيعني قبل كانوا يعطونا 2 liters or 3 liters fluid. Fluid is not going to replace blood. If he needs blood, he needs blood. If he loses blood, give him blood. Early giving blood to the patient is much better. Why? بتقلل عندها الcoagulopathy, بتقلل عندها الهemodilutional, complicate will be much better survival rate, will even help him also to prevent the bleeding as well, or going to the ICU, the kind massive amount of bleeding. So blood loss is the most important fluid in trauma. Blood loss can lead to a shock and death, and fluidization is crucial. Yes, we give fluids temporary, but we have to have a limit. ما بعطي أنا 10 لتر of normal saline وما أعطي ولا unit of blood. This is ridiculous. He is bleeding blood, not bleeding fluid. Exactly. Hemodilution, coagulopathy, صح ولا لا? We don't want to do this. نبي نعطيه more something physiological. طيب. Okay, so agree. We need, once the patient is bleeding, need to give blood. Okay, fluid can be early fluid resuscitation. That's good, that's important, but we need to go with early blood components transfusion. Now we talk about pain. The patient is coming with trauma. Trauma is painful, especially the patient is conscious. He's painful, right? We need to give him a combination of pain management. I don't want to give, okay, he's got under pelvic fracture, under fracture in his arm, fracture in his limb. But the patient, although he is screaming of pain, but he's hypotensive, he's bleeding somewhere else. Oh, هنا نعطيه painkiller, I knock him down, maybe he'll be hypotensive, ولا ما أعطيه painkiller. You need to respect patient, you need to respect their pain. So I will give him painkiller. We give IV paracetamol, the safest one. If not, I can still give him some other inhaled medication. I can still opioids. Do you need to give non-steroidal? Yes, no, it depends on the allergy situation with the patient or not. But as a concept, pain management is very important in traumatic patients. They do have pain. مو معناته انه اخليه I let him scream. Somebody coming with dislocations, somebody coming with open fracture. صح ولا يعني انا I've seen patients coming with البون طالعه برا. ما بعطيه something painful, something to control his pain. Come on. It's a torture. We have got in emergency medicine, we have got the tools to give him medications, to give pain management, and I've got the tools to monitor him and to overcome any side effect which could happen. صح ولا لا؟ بس معناته والله لا اخاف انه عنده تروما ويز بيت اون ذا بوردر سايد، لو اعطيته شيء ثاني اعطيه والله مورفين او شيء he will drop down, he will collapse. No, I will give him. I have to be very cautious. Yes, be very careful. But of course, you have to monitor him. You have to respect pain. You cannot reduce somebody's fracture without giving painkiller. It's a torture. هاي يعني إجرام يسمونه صراحة، حرام. So we have to respect, you have to do some sedation. You don't give him IV medication systematic, give him block, nerve block. Okay, around the place area itself. Okay, you can give a nerve block. You can do whatever you want, any reduction of any dislocation with a simple nerve block will not compromise his systematic, will not compromise his circulation as well. So lots of modalities that emergency physicians are capable of doing it. They have the needed skill. Maybe he does not know. We can call the pain management, anesthesia. I want a nerve block over here. He's got a pelvic fracture. He's got a femur fracture. I want to reduce it. تعطي ring block. صح ولا لا؟ nerve block, ring block. You can do that, especially if the patient is in pain. صح ولا لا? Okay. Now we come to pearl number 13. What is torso? Hygienic package. A torso is what? The chest, the abdomen, the pelvis. يعني ما يصير you cannot it's the كما as a one package كلهم عيال عم مع بعض ما يصير you take only one thing and don't do the imaging for one thing. Oh, I'm gonna do CT scan only for his pelvis only for the chest. طب انت عندك الchest والabdomen والpelvis they're all together. Don't do only one CT scan for something. Once you do an imaging for one of the torso components, you have to do the full torso. Mostly they all come together, all or none. Okay, so the torso includes the chest, abdomen, pelvis as one unit in trauma managing because lots of common things. All they share the same blood vessels, the nerves, the structures. It's all in one package. It's all one area. مثلا مو تقول والله انا بسوي له اللور ليم والبلفس بسوي له الرايت لور ليم والبلفس بس بدون الابدن بدون الشست لا. It comes all as one. Exactly يا جمال as a trunk كله كامل. So we only do it as one part and once it is needed imaging I have to do the whole entire region to be scanned. I will not only choose only to do one part of it. ليش؟ and if we only choose one part of it we might miss it. صح ولا لا؟ اي والله البلفس زينه بس انا ما ادور على الشيست يمكن بالشيست طب ممكن الشيست في عندها بلانت انجري كان عندها كونتيوجن صح كان عندها سمول بليدنج كان عندها ديفراماتيك انجري طب شو الفائده؟ It's all one part. So whenever I go for a torso any of the torso it's all together مع بعض. We don't say it's one and or I will do this or I'll do this. It's part of the having a proper diagnostic workup حق البيشنت. طيب we'll go paper number 14. We are okay, guys? Fine. It's a pan scan. Yes, it's a pan scan. It's a pan scan. We do a trauma pan scan. طبعا different hospitals, different protocols. Some hospitals they've got only one order in the system, trauma pan scan, and they do it all. Some people they do it only with contrast. Some other hospitals without contrast. It depends on your local protocol. But do recommend once the patient is trauma and he's stable enough, we do the pan scan for this patient just to rule out, just make sure that we did not miss any of a bleeding or a fracture. طيب. Now imaging and transfer. Now very good question. We always talk about trauma. حين I got a patient coming to my hospital. My hospital is not a trauma center. What shall I do? Shall I do for him CT scan or ultrasound بعدين أودي another trauma center or not? So definitive care cannot be provided. Do not delay for transfer by requesting imaging. طب انا سويت له اكس راي حق الشست والابدومن. طب في النهايه I don't have a surgeon. I've got a small hospital. small مركز صحي عندي انا في الحي عندي في الفريج زين. وبعدين صار عندي تروما بوليتروما جاء عندي I did my properly primary survey within 30 seconds. I put IV line. I packed him. I immobilized him. I don't need to waste time. I cannot do it. I don't have a surgeon. I don't have an OR. I don't have an ICU. But do not delay the patient. Do not do any imaging. ليش تسوي له x-rays و CT scan وتسوي له كذا and he's going to go to another place who are going to repeat it again. So always transfer to the most appropriate center is a priority than doing any other diagnostic imaging. You only do the priority to stabilize his ABCs or CAB. You stabilize ABCs, highly priority, stabilize. I did intubate him. I did make sure that his breathing is fine. ما عنده pneumothorax. I did put for my lines. I did start even blood to give it to him. And then he's fine. He's good to go. Let me take him to the proper trauma center. Trauma system. Yes. every EMS. طبعا احنا عندنا الحين something very nice. EMS عندنا هنا الأحمر عارفين وين مستشفيات أقرب منشأة صحية. Regardless whether it is something governmental, something for MOH, for military, for التعليم العالي. The EMS عندنا dispatch they know أقرب منشأة صحية who are the most appropriate center they will transfer it. So كل EMS they have عندهم وين موجود trauma center. عندك مثلا المنطقة الفلانية regardless of the eligibility. هاي ولله الحمد هاي system we have it here and it's doing it very 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 well. Now we talk about pair number 16. جاء المريض معانا سوينا له تورسو سي تي سكان سوينا هيد سي تي سكان هيز فاين. طب والسي سباين وين راح السي سباين؟ سي سباين للأسف sometimes they said no he looks fine okay but why not? We should always once he's on the table to do the CT scan you always don't forget to put a C spine as well. C-spine can, a long time when we used to be a resident, we used to say, oh, cross-table cervical spine X-rays for the primary survey حق trauma. But now it's not anymore. He's going to go for pan CT. So put the cervical spine. Very important to me know هل في عنده cervical spine fracture, في عنده any compression, and any kind of something which needs an early surgical intervention to call the spinal surgeon ولا لا. Something very important. So do not miss it. And he's already, once you put him on pan CT, you just add the order, and that will be, we should always not ignore the C-spine imaging as well, because it's a crucial. And of course, you need to properly immobilize the patient. ليش قلنا ذكر قلنا أول هدف مالنا إن إحنا I remove my backboard, I remove my cervical spine, my cervical, my C-collar support as soon as possible. طيب. Okay. Per number 17. Restation lines. شنو اسوي له؟ I have to do trauma restation. I don't want to give that yellow cannula اللي استخدمها حق الانفنت. I want to give him 14 to 16 gauge. Anti-cubital lines are recommended for trauma restation. ليش؟ كل ما كان الدايمتر higher, I can infuse more fluid faster without any resistance. Not only fluids and blood. Of course, there's something called level 1 transfuser. Level 1 transfuser is a very effective. It transfuses it actually as if it pushes the fluids and plus the blood, and it also rewarm it. طبعا don't forget one of the major challenges in management of a trauma patient is hypothermia. شلون hypothermia واحنا عندنا الدنيا حر؟ يقدر احنا قاعدين في الاي سي داخل المستشفيات صح ولا لا؟ In our hospital we've got air conditioning, temperature about 23, 22, sometimes 20. Okay, what normal saline or blood is very cold. They put in the fridge. So we will induce hypothermia with the patient. طبعا hypothermia leads to coagulopathy. For level 1 transfuser is a device which is called level 1 infuser. Make sure that we infuse the fluid in a kind of with the pressure after rewarming it. فيكون more of the same temperature of the body. So we prevent having any kind of hypothermia or coagulopathy. Okay, good. We're doing very well. Now, what is MTP? What is MTP? Massive Transfusion Protocol. طبعا major trauma. طبعا the best thing is that the patient is losing blood and the chest tube يطلع blood من chest tube عنده draining يطلع هالكثر blood من عنده. The best, why can't I use this? يعني if he might have some allergic reaction to other blood, but his blood he will not have it. So massive transfusion protocol, in case of severe blood loss, I need to do auto transfusion, or I need to have a protocol. Oh, he lost 3 units, I want to give 20 units. I don't replace blood with ماء وملح. Blood should be replaced with blood and coagulation factor as well. ما يصير blood ده أنا أعطيه normal saline. ما يصير blood أعطيه ringar lactate. He lost blood, I need to give him blood. That is ridiculous to give him only to lose 2 units or 3 units of blood and then give him only normal saline. It will not help him. As an adjunct, we can give tranexamic acid, 2 grams tranexamic acid, and calcium as well. So TXA is very useful, one of the very safe medication that we can use, and will help also. It will not replace the blood loss. It will help to control the ongoing bleeding. Okay. So we just said analgesia and post endotic intubation. Yes, once you intubate a patient, you don't want to keep him without sedation. Once you intubate a patient, he will be awake. يعني حتى level of consciousness ما كان about what degree, but he'll be awake. Imagine that yourself. Okay, you are a patient and you're awake. You know, you can see everyone around you. You can hear him. Okay, a tube is in your mouth. You cannot move. Maybe you are restrained and you cannot move anything. So you have to sedate him. It's a torture to keep a patient. Maybe he's an endotic intubation. حاطين له splint, عنده fracture, حاطين له Foley's catheter. You put tubes everywhere, and he is awake. He's fully awake, and you do the traction and all of that, and he's in pain without you giving him any sedation. It's not inhuman actually. So post endotic intubation, I should make sure that you've got a proper analgesia, and حتى لو intubate you still have pain. حتى لو عندنا sedation as well. حتى لو عندنا sedation as well. I will. And he has to be sedated after endotic intubation. And of course, I have to avoid awake paralysis. I remember once when I was a medical student, I had somebody, I had a patient. I mean, I was to go and I saw, oh, he's intubated, but he looks at me. Imagine somebody who's intubated and he's moving and he's moving all his. He looks at you, but he cannot move. Imagine you are paralyzed, but you cannot move. That is a torture. Actually, that's a torture. والله. فintubated, give them analgesia, sedate them, respect their pain. They do have pain. They need to be sedated as well. Okay. Now, per number 20. Are we doing well? Well, what best analgesia? You are absolutely right. Analgesia, you need to, it depends on the vital signs of the patient. Is he hypotensive or not? Is he normotensive or not? Okay, we can go with ketamine, we can go with the fentanyl, propofol, depends on whatever is the vital signs and the type of injury and the comorbid illness of the patient. Okay, so there is no such right and wrong. There's no such well, it is gonna be with this or that, but you have to be based on the clinical situation, the comorbid illness, and the existing vital signs. So it's a good question. I'm gonna give you a handout. كل السلايدز. Don't worry يا رفال. I'm gonna share it مع سلافة. انزين الهاند اوت حق السلايد كذا ولا يهمك. I already prepared it as a PDF. اوكي يا سلافة. Thank you. طيب let's go to point number 20. pan CT scan mechanism alone. طبعا احنا يعني هل mechanism alone is it enough نسوي له pan CT scan؟ طبعا نقول لك لا، ليش انا اعرض المريض ل lots of exposure و lots of radiation وعنده كذا is it enough؟ هل كان severe mechanism of severe mechanism of injury ولا لا؟ طبعا clinical assessment of the very crucial. They need to do CT scan ولا لا؟ هل البيشنت is conscious oriented؟ هل البيشنت is totally awake and can tell me I've got this or not؟ mechanism plays a major role as well, a major part as well in determining shall I go for pan CT or not. طبعا vital signs، يعني واحد جاي لي vital signs he's tachycardic, young man tachycardic, blood pressure on the lower side. اوكي، عنده bruises over his chest، عنده الابdomen شوية في ecchymosis. I will combine all of that to decide to do for him for imaging or not. I do agree with you all. And we are doing a lot of imaging. We've got a lower threshold to imaging actually. بس طبعا لأن due to the availability of the resource available الحمد لله, and we are with any trauma center they do have such, all those CT scan becoming now widely available everywhere, and lots of issues, lots of injuries, small subtle injuries were actually discovered by such only lower threshold of imaging. So trauma codes, polytrauma, more than one system is available. Mechanism of injury, mechanism of the accident is very bad. I will do that. يعني أنا اليوم, like few hours ago, I had a small child. Okay, the child is just talking to me, but just complaining of a mild lower limb. But the child was in a car. I mean, just like today الساعة 4 قبل ما أنا خلصت الشفت، على آخر شفت جت الطفلة. The car was hit by a bus. The car was spinning, hit the big concrete barrier. The child was actually يعني طارت from the back seat to the front seat. Conscious oriented بس. This kind of very kind of severe mechanism of injury. تقول السيارة دعمها باص، يعني مو دعمها باص وتم تلف ودعمت فيه صبية أو كونكريت. Such an injury with a small child. I cannot rule out any kind of an injury to her internal organs. I cannot rule it out. I have to do the CT scan. It looks fine. See, ultrasound for EFAS was negative, but even though I cannot rule it out, so we have to go with that. So it's more safe for the patient to do that. So better to do a pan scan rather than not to do it. Absolutely right. I'll not do something and leave the other one. Do a pan scan. Every hospital now, they have trauma protocols, or they do always include the pan scan as well. Okay. Now, dislocations. Excellent. Very good. And عندنا dislocation. يعني احنا بعض الأحيان خصوصا إذا كان البيشنت is polytrauma أو unconscious. احنا مشغولين والله level of conscious ماله وانتبيتد him. We do not identify the dislocations. Early identification of dislocation and early reallocation is important. ليش؟ لأنه we will prevent arthritis. will prevent any vascular necrosis, will prevent any injuries to the joint itself. So time is critical. Each minute joint dislocation increase the risk of arthritis. طبعا ما تبي واحد عقب ما يسوي له تروما يطلع عنده arthritis وعنده he needs to go for treatment for a couple of years only to treat his shoulder because we missed his dislocation. So once you do primary survey, you identify there's no life-threatening or limb-threatening conditions. You fix the patient, and you are okay. He's stable enough now. You can go and make sure there are no dislocations, and many fractures were missed. Many dislocations actually were detected later on after admission to ICU, missed by the ER because we were overwhelmed with the other very apparent. But of course, it's something that we have to avoid it as well. So one of the pearls in trauma management that we have to look for dislocations and reallocate them as early as possible. Okay, cardiac arrest. Wow. I had another talk about traumatic cardiac arrest. What is traumatic cardiac arrest؟ هل هو يعني خلاص واحد عنده صار تروما جاي للاي ام اس responded to a major accident راح ولا he is pulseless, no pulse, no breathing. Okay, let's do CPR for him. Oh yeah, we'll do for him CPR. طب بعدين it will not work. It's not like any other medical, not like any medical arrest. There are something called HOTT. What is HOTT? The aim is that to rule out hypoxia, obstruction, tension pneumothorax or tamponade. الكارديك arrest في non-traumatic patients. جاي واحد عنده cardiac arrest. Could be صار مع ACS, MI, PE. He had even one of those reasons. That's why he had a cardiac arrest. But traumatic cardiac arrest, those are the reversible causes. So that patient with an MI, okay, or cardiogenic shock, or an MI, or a ST elevation MI, or there's arrhythmias. If you go on CPR, chest compression, you go with the ACLS protocol, you give a defibrillation, you'll get him back. يعني one way or another, inshallah, especially if they can early CPR. But a traumatic patient, if you do a chest compression for somebody with obstruction, pneumothorax, okay, tension pneumothorax, and the tamponade, whatever chest compression you do, if you did not reverse the cause, he will not come back. صح ولا لا؟ Somebody's hypoxia. If we did not correct his hypoxemia, do a chest compression or CPR, تعطيه epinephrine, he will not come back. So the reason of traumatic cardiac arrest, hypoxemia, is because of his brain. He's not able to breathe. He stopped breathing, and obstruction, and the foreign body. Okay, maybe and the bleeding. Maybe need to have a surgical airway for this patient. صح ولا لا? Obstruction. He's got a surgical airway. You need to go and creak him, right? Cardiac tamponade. Whatever chest compression you do, if you did not do a pericardiocentesis, he will not come back. Tension pneumothorax. If you did not do for him needle decompression for by ICD, he will not come back even with chest compression. So the name is for HOTT. طبعا when you talk about ACLS and let's talk about it. In ACLS, it is it's an ATLS, an ACLS. That's reversible causes, tension pneumothorax, tamponade. It's also even mentioned in ACLS. فلما نتكلم احنا عندك هنا في البيشنت with trauma, traumatic cardiac arrest, yes, I need to know. He has got no pulse, he's got no breathing. أول شيء, is his injuries are compatible with life or not? If somebody coming with an injury not compatible, somebody died on spot, somebody major injuries, he was hit by a car, run over by a bus, and he's got no pulse. This patient has got major severe vascular injury that are not compatible. He will not be able to get him back. I understand the critical situation. Understand it's very, 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 very critical, and actually it's not easy to say, oh, he's not. We are not going to do any CPR for him. No neurostation, but always look of the HOTT. Okay, hypoxemia, obstruction, tension, pneumothorax, and then we go with that. Okay, and of course, traumatic brain injury. It is, but it is the cardiac arrest. Traumatic brain injury. People will not die because of TBI, okay, traumatic brain injury, people will die because of bleeding. People will die because of tension pneumothorax. People will die immediately or will have an arrest because of a tamponade immediately, I'm just saying. TBI, it's a longer term, but of course will be even will have a secondary TBI because of hypoxemia. You're absolutely right, yeah. المهدي الزين مهدي. Okay, طيب. 23. trauma screen for medical causes. You have to have medical causes for trauma screen too. You have to screen him. هل في عنده medical causes because of that? Did he have a trauma because he had, okay, we have said, okay, this patient, an elderly Baba, history of fall, and he has got a trauma because of, يعني fall down, fracture pelvis, وعنده bleed وعنده كذا. طيب, why did he fall down? Is there a medical reason for that? Oh yeah, Baba is having brain injury. Brian Baba is having a stroke. He could not balance himself. He fall down from the first floor all the way down. جاء عندنا with جاء عندنا with a trauma, hypotensive, pelvic fracture. But شنو الريزن ماله؟ الريزن ماله والله he had a medical cause. Another young man working in a factory, suddenly he had a trauma. He's got a amputated upper limb or lower limb. What happened? He's a machinery operator. The medical cause, he had a seizures, unwitnessed seizures. He had a seizure, he could not control himself, went under that machinery, had an amputation, lost his limb, bleeding, coming with hypotensive tachycardia. Okay, trauma, but في وراها medical cause. صح ولا لا؟ فalways look at about assessment. It's not only, don't be always, especially احنا as an emergency physician, we should not be as only narrow-minded. Exactly. يا جنى, hypoglycemia. طب كان with hypoglycemia صار عنده hypoglycemia, he fall down, صار عنده head injury. طب انا بعالج الانجري. طب ليش هو طاح في النهايه؟ اجت hypoglycemia, اجت arrhythmias, is something صار معاه seizures ولا لا؟ is it electrolyte imbalance? Absolutely. So always look at the, is there a medical cause of that؟ هل مع drug intoxication؟ ماخذ drugs overdose؟ هل ماخذ مثلا overdose of beta blockers؟ ماخذ overdose of whatever uh, drugs of abuse. يعني lots of things can lead to trauma. They lost control of themselves and they can get a trauma. So don't be always narrow-minded. Don't look only at the complaint. Look, is there any kind of medical cause? Could it be a medical cause which caused that? صح ولا لا؟ واحد ماشي بالسيارة suddenly lost consciousness, دعم طق الصبية وصار معه وانقلبت السيارة وهيد انجري وتشست انجري وحطينا تشست تيوب. طب في النهاية ما نرجع ورا, we go back retrovirally. طب انت you were driving the car, what happened? Oh yeah, I was having chest pain. Okay, I was having a chest pain. And then I don't know what happened. And then I find myself here in the ER. Oh yeah, really. Chest pain معناتها الرجال صار معه MI, infarcted, lost conscious, صار معه arrhythmias, ما وعى شنو صار معه, دعم, شو اسمه, صار معه تكسر الرجال, وبعدين جاء عندنا with a trauma. But the main reason was not the trauma. The main reason was he had cardiac issues. صح ولا لا? Actually, I remember one of my exam when I did my board, my exam case. I had an elderly Baba who's got he had a trauma, actually, a polytrauma. But when I going back, I thought, okay, I want to have an EKG for this patient. He was 70 years old, history of fall, عنده كان fracture وكذا, وعنده كان fracture spine, and head injury. I said, I want to have an ECG. An EKG showed an ST elevation MI. Oh my God, this patient has got an ST elevation MI. And the reason was his MI, not only the trauma, the reason which happened to all of him. Okay, we go back. Osmotic therapy, this is a bit kind of much more advanced, guys. I'm not going to go for it, but I just want to tell you that I just want to let you about osmotic therapy, the 3% in ACL. Okay, osmotic therapy, we use it for patients with raised ICP. Okay, we can use it anicodilate pupils, deteriorating neurological deficit or status, GCS. There's a drop in GCS, we can go hypertonic saline, and we can go for a mass effect of brain swelling, and of course, if there's any Cushing triads. So Cushing's, so those triad is very, very crucial, and actually the patient could just go if you do not attention to it. His patient's hypertension, bradycardia, and irregular respiration. Means he is cushioning. He is actually cushioning them. If we did not give him his hypertonic saline, he just simply will go. He will just simply he will just go. He will not. You'll not be able to bring him back. So any patient comes to you, you've got the hypertonic saline, you're on osmotic therapy, his hypertension, his bradycardic, he's got a problem with irregular respirations. Is he cushioning? Yes. Let me give hypertonic saline. Always, many of the trauma guidelines said avoid the mannitol unless it is recommended by the trauma surgeon or by the neurosurgeon. So mannitol not recommended, okay, for such a thing. Also be always done with a neurosurgery or neurosurgeon's advice. But we as an emergency physician, we should not. We should think of the hypertonic saline. Just to let you know, there is something called hypertonic saline. Okay. Now, do we need to give norepinephrine infusion? Do you think we should give norepinephrine infusion? Patient coming, I give intubation. I did intubate him. And of course, remember when he told you we don't go for ABC, we go CBA? Because if you go with airway breathing, you might even, once you intubate him, the patient might relax by down and even might crash. So the last thing I want to go with my airway, if as far as I'm able to ventilate him properly with the bag mask valve. So I need to put a norepinephrine as a standby. I need to rule out any other causes of hypotension. Okay, like blood pressure drop. Duper. What's the reason for his blood pressure drop? Is it only because of the medication I'm giving him? Is it only as a matter of the ongoing blood loss? So always keep an norepinephrine infusion as a standby, but should not. I would not like to use. We always my one of my senior doctors was telling me you have to fill in the tank. Don't use pressors with an empty tank. I said, yeah. I said, oh, his blood pressure is low. I want to give something pressors. I want to increase blood pressure. I said, okay, you increase the blood pressure for a full tank. Fill it up, then you can do it. If my tank is not full, how can I increase the blood pressure? I'm losing blood, and he lost a good amount of blood. I'm only giving him fluids, myomilh. Will not replace it. Fill up the tank, and then you can go your presses. But without filling the tank, you'll not be able to get a kind of a near normal. And of course, always keep in your mind, you don't want to aim to a normal blood pressure. You have to have something called permissive hypotension, something which is good enough. Now, we'll talk about another pill number 25. Are we okay, guys, with the time, or we are getting tired and sleepy? Are we okay? Just somebody just tell me chat. Are okay? Do you want to have a break, or we just can continue? Super okay. Thank you, Salafa. Thank you. All good. Excellent. I'm very happy that all my audience are conscious and oriented. Thank you very much. Okay, we'll continue. No worries. Got only a few slides to go. So point number 25, it's pain and intoxication. So pain can be a symptom of intoxication. Yes. So we have to give something to control his pain. I want to know, is he intoxicated or not? Give some kind of distraction. Distract he's not concentrating. The patient is confused. Is it something? Is it because of his pain or something more of central or central neurological? And of course, we need to know pain and intoxication, they do exist on a spectrum. So is he having really pain? Is he not able to concentrate with me? Is it really because of the pain? Is it really because of other reasons? Is it really because of the hypoxia he's getting, or because of the brain injury he's having? So we need to always consider this. Don't think, oh, this patient is intoxicated. We'll not take it for real. I don't think he's fine. He's drunk. He does not know what's happening. No, it can be not only drunk, it can be something else. Maybe he had some drink of alcohol, fall down, banged his head on the floor, and he's got a brain injury. And he's confused or intoxicated, and is a kind of a confused and distracted because of the brain injury, not because of the intoxication. So we cannot rule it out. You don't say, oh, no, no. He's only because he's alcoholic ومضيع لأن he's alcoholic يمكن نخليه maybe 3 4 hours he will wake up. No, we cannot. I cannot rule out a brain injury or traumatic brain injury without clearing it, without having the proper imaging. All right, GCS, pupils and lateral signs. Always document your GCS. Patient comes in here on arrival, document your GCS. Document his pupil size. Document his lateral length. It's very important. I know we tend to rush to go with airway breathing. I'm going to do what's secure of that, but at the same time, I need to document. At 7 o'clock, he came with a GCS of a 12. At 7:20, this 12 became 10. At 8 o'clock, the GCS dropped to 8 and I have to intubate him. So this kind of symptoms, okay, or this kind of sequential and documented with timing gives a good clue to the receiving trauma team what is the progress of the patient. All right. So record Glasgow Coma Scale before endotake intubation. Okay. Assess the pupil size and reactivity to light, and of course, note any signs of weakness or paralysis on the side of the body. So just document it before you mean it just takes about less than 10 seconds to observe is he moving all four limbs or not, as simple as that. And then you calculate the GCS. Before intubation, GCS was that, because once the neurosurgeon comes in here, said, what was the GCS? I don't know, I can't remember. I did not intubate. I mean, I don't think I forgot. If he was intubated in the scene, ask the same question for the paramedic. Guys, was he walking? I mean, there's something called he came out walking, was talking to them conscious, and then suddenly arrest. And that's a traumatic brain injury. Okay. Is it subacute? Is it subdural? What happened to him? He was talking to them and suddenly arrest. So if they tell you this kind of scenario, and oh, he was okay, then you get to know what is the diagnosis immediately, and you can even activate all your trauma team and your neurosurgeon. Surgical bleed on imaging. So you did for him, okay, patient is stable, that's fine, he's okay, E5 is negative, took him to CT scan, and there was a bleed, okay, major bleed. Will you continue do that? Major bleed, and of course, quickly to OR. Do not waste time. Somebody having massive bleeding, the radiologist should be actually, ideally, the trauma team leader, the emergency physicians, and the surgeon should go together to the CT scan suite with the radiologist. They can see interpretation of the images on spot when he's on the table. Significant bleeding, this patient does not go back to the trauma bay, goes to the OR. You need to open him up and control the bleed because you don't want to lose him. I mean, he can control himself. His hemodynamically can be stable enough up to a certain amount, then he cannot go on. So big bleed, and if the surgeon with you, take a decision, take him to OR. Just push him for that. Negative CT scan. Okay, again, negative CT scan does not mean, oh, the patient is fine, let him go home. Does not, maybe because some other injuries. Okay, maybe because some very small diaphragmatic mesentery or pancreatic or bowel may not be visible on a CT scan. Many cases, especially by severe mechanical, this is why, especially with polytrauma patients, now the protocol, such patients will be admitted in trauma bay under trauma team, and then they'll be evaluated, and then observation for 24 hours. Next day, the CT scan will be read again, revised again by the more senior personnel, by the consultants, by the more expert in traumatologists. They can see that they might even repeat the CT scan again within less than 24 hours. But if you have got a clinical sense that there is something on with that, even if it was a negative, I will just put him in, admit him for observation for 24 hours. In case there was any issues, I will just take him again to OR. Okay, now we go back Pearl 31. Trauma registry now everywhere. Now in the kingdom, we're starting to have the trauma registry now. It is starting big project. We had a conference last week in Khobar in our hospital, and we had one of the pillars of trauma surgeons in Kingdom of Saudi Arabia, Dr. Thamer Nouh is a trauma surgeon. We're talking about trauma registry and how much they have to have a registration, and MOH I think is working very hard on it to have a proper trauma registry and data on the trauma. Why is that important? Actually, to monitor the practice. Are we doing all the same good to the patients? Are we having our own trauma protocol being implemented all over the world? We need all over the country, improve the care and get the outcome. How is it? Is it good? And of course, maybe doing some procedures is not good. Maybe we are delaying it. Maybe we are overdoing, or maybe we are underdoing it. So have a trauma registry will give you a good reflection of what's the situation, what is needed to be done. طبعا when we talk about motor vehicle accident, lately, I mean, we had one of the highest number of accidents around the world in Saudi Arabia. But when they said, okay, we've got a very high mortality, very high number of accidents, they did kind of intervention, which is by what? By implementing SAHR, implementing a very hard, tough traffic laws. All those interventions led to really prevent the injuries, even to decrease the trauma, the trauma because of motor vehicle accident. So having a trauma registry is one of the most important things that we all have to be. I will have to encourage and keep it on with us. Trauma system is not only me and you sitting in the emergency room waiting for our trauma. It starts with prevention. It starts with prevention by what? Making your working area safe. Making our kids know how to be very safe. Okay, you yourself, anybody who's having, for example, any medical illness, should be avoided from doing any kind of from driving, for example, seizures or epilepsy, not to drive. Somebody coming with arrhythmia should be able to should be always having their own companions. And then after prevention, we go with the rehabilitation. After trauma, polytrauma, young people had fractures. We need to rehabilitation with them. We open rehabilitation centers to bring them back to the community as soon as possible. And of course, advocacy for our patients. Patient had trauma, polytrauma. They need a lot of support because imagine a young man was walking, suddenly he's on a wheelchair for the rest of his life. I mean, yeah, even just now today, I saw a very young man, he's about in his 25 years old, very young, handsome young man, but he is paraplegic. He's on a wheelchair. Okay, he does not feel his lower limb. Said, what happened to you? Very young, mashallah, handsome man. Yani. Said, I had a motor vehicle accident, and then I lost my power in my both lower limb after the motor vehicle accident. He was in a wheelchair. He was in a Foley's catheter. He's coming with bed sores, recurrent UTI, and all of that. So those people, they need advocacy. They need some kind of support groups. They need people to help them how to accommodate this life, and of course the rehabilitation to come back to the community, how they can live back. It's not only a trauma, عالجناه وخلاص. It's a very big burden. Does it make a difference? Yes, we can make a difference. We can make a big difference because we own the first golden hours. Golden hour, if we correct the hypoxemia initially, we will help them. If we correct the hypovolemia, we will help those patients. If we did prevent secondary brain injury by having a proper ventilation for this patient, we will do that. If we did we did prevented the cushioning effects, for example, in patients, we will be helping them. If we took this patient to OR, initially, we'll prevent massive bleeding and losing part of his bodies or even limbs as well. So life or limb-threatening conditions will be all detected within 1 hour. If we did do our part, we make a big difference. So why trauma is important? Is it just because of fancy? Well, أنا أحب trauma, I am a dermatologist. No, because it's the leading cause of death under age of 40. Imagine it. Shabab, they are supposed to be building the country, building the community. The most يعني الفنوان شباب عندهم their own طاقات, all the energy to help the community. Unfortunately, they are instead of being a positive input, they are kind of a burden. They need a lot of care. They are not able to work and build up. So one of the leading cause of death طبعا لا يقدر بثمن, big loss to the whole families. And of course, fifth leading cause of death overall, يعني أقل من 40 سنة leading cause, وخامس سبب للوفاة بعد ذلك. تقريبا 5 مليون وفاة سنويا حول العالم. Imagine 5 million death only because of trauma. Well, we don't talk on trauma about motor vehicle accident ولا falls ولا injury. It's a lot. It's all types of trauma. How big a difference? We can make up to 80% إذا احنا استغلينا golden hours. Golden hour, early identifications, early intervention, take him to the proper trauma center, having a proper trauma center with protocols, utilizing our resources in a proper way, we can make a difference. Up to imagine 80% of those deaths or people or patients living their lives as a kind of demanding lots of support are back to their normal life in the community. Makes a big difference. So we talked about pearls of trauma care. We talked about what things we should avoid, what things we should know. And I hope that you enjoyed your my talk. Um, any question, any comment, I'll be more than happy to answer. الله يعافيك يا شذا. So did you enjoy it? Was it fruit?
يعطيك العافية دكتور.
الله يعافيك يا رب، إن شاء الله
شكرا
مشكورين.
ليك وشكرا لجهودك.
الله يسلمك يا رب إن شاء الله. وأهم شيء استفدت ويعني it was a good eye opening for lots of things in trauma. طبعا trauma is a huge subject. ناس تاخذ فيها fellowship، ناخذ فيها سنوات تتحضر في التروما. But it's an interesting time عندنا الواحد ياخذ يعني أشياء الجميلة يعرفها. Then you can go and explore more deeper and deeper إن شاء الله. موفقين يا رب إن شاء الله، موفقين يا رب إن شاء الله. Oh, thank you very much يا سلافة. Thank you very much. I really appreciate it. واحنا حاضرين معاكم، اي شيء تبون دائما انتم عيالنا، و we'll be more than happy to help you always. ان شاء الله هاي واجبنا ان احنا دائما نعلم. we always have to educate ourselves. all the best. انا سلافة برسل لك الهاند اوت الحين على الله يخليك. thank you آل زين مهدي, thank you very much. I appreciate it. I'll send you the المحاضرة